All right, I think most are in now. So these are the periodontal ligaments, and when you do a force, you see that now the blood vessels, with increased force, the blood vessels are getting occluded, and this is what we don't want to happen, because the blood vessels are supplying the periodontal ligaments with oxygen, which is very important. And you know that the primary triggering factor in making a tooth movement is actually the hypoxia, or the decrease in the oxygen levels. When the oxygen levels are decreased, you get prostaglandins and other factors to be poured into that area, and the osteoclastic activity begins. So there are two types of continuous, or what we call constant forces, that can be applied to the tooth. We have a light force and we have a heavy force. So a heavy force is going to occlude the blood vessels. Light forces are going to induce the cellular activity without closing the blood vessels. So the effect of light continuous force is that you have osteoclasts formed, removing the lamina dura, tooth movement begins, and this is what we call a frontal resorption. And frontal resorption will mean that this surface area of the bone is going to be resorbed, which would result in what we call translocation. So you get a translocation of the socket. So this is how a tooth moves. All right. So frontal resorption, and this is a slide that comes frequently in the M-ortho exams. It's a histological cut section taken in monkey or a rat. And here you can see clearly that this is the alveolar sign and this is the tooth sign. And you can see here more than one cell, more than one nucleus in a cell. Can you see that with the arrow? This is an osteoclast. And when you see this osteoclast, you would understand from these osteoclasts that this is the resorption sign. And because resorption is coming from the periodontal ligament to the inside, to the tooth itself, from the tooth to the bone, we call this frontal resorption, all right? And frontal resorption actually takes phases. Tooth movements with light forces takes phases. So the first phase is called what we call the mechanical phase. And this mechanical phase, in this mechanical phase, there is compression of the periodontium. So the tooth in few seconds seems to have moved like half a millimeter because of that. Not half a millimeter, because the periodontal ligament is about 0.2 to 0.3 millimeter in diameter, in cross section. So it moves a little bit in that space. Then phase 2, in which there is preparation for the cellular activity, and phase 3 is actually when bone resorption happens. And in frontal resorption, tooth movement actually happens within the first 2 days. So after you apply the light forces, you can expect that tooth movement begins, meaning that resorption begins in 2 days. So what about the heavy forces? And in heavy forces, what actually happens is that because the heavy forces are applied and transmitted to the roots, you can actually compress the blood vessels to the point where they get occluded. And if this happens, you are preventing all the oxygen supply and preventing all the cascade of events from these nutrients and prostaglandins and everything coming from these blood vessels to stop. And when this happens, you get what we call aseptic necrosis, means that you get a death or hyalinization or a glossy-like structure. And this is as well a popular slide that you can find when you go to an M-ortho exam. And you can see that the osteoclasts now are coming from within bone, meaning that because this is a hyalinized area, can you see this glass appearance? Yeah? Can you see this glass appearance? And this is the tooth surface, this is the bone surface. And no osteoclasts here found to do the frontal resorption. Osteoclasts are coming from underneath the bone. And we call this undermining resorption. And the problem with undermining resorption is that when it happens, actually, it takes a longer time. So the tooth is going to move in like 14 days. From 7 to 14 days, you would expect movement to happen. So in the phases of tooth movement using heavy forces, there's a mechanical phase, but there is a longer cellular activity phase and a slower tooth movement. So if we make that comparison, we know now that tooth movement begins at an earlier phase than when you do with undermining resorption or with heavy forces. So can we actually have in all our orthodontic treatment light forces? It is a little bit difficult to have that. And in many situations, you get a bit of both, a bit of frontal resorption and a bit of undermining resorption. And depending on the amount of force that you apply on the teeth. So the more lighter you are, you can expect the more frontal resorption and less undermining resorption. While on the contrary, if you apply very high forces, you get more undermining resorption and less of frontal resorption. So the main thing I want you to get out from here is please try to use light forces in all instances. So at all times, please try to use light forces. Why? Because you want to get frontal resorption. And this is our conclusion, that frontal resorption facilitates orthodontic tooth